Welcome to the Lymphoma Research Foundation's Update on Follicular Lymphoma webinar. I'm Susan, and I will be your operator for today's call. During today's call, you will hear from an expert speaker and will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the webinar, a link will appear on your screen. Please follow this link to complete the evaluation of this program and gain a certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now, I'm pleased to introduce Jessie Brown. Jessie Brown is an Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jessie.
Thank you. And thank you to each of you for taking the time to join us on today's Update on Follicular Lymphoma webinar. We'd like to first thank our sponsors of this webinar, Bristol Myers Squibb and Kite, a Gilead company. Before I turn the program over to our speaker, I want to briefly share information with you on the Lymphoma Research Foundation. Access to expert disease information is so important, and we're thrilled to be able to bring you this educational program. LRF is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or via LRF's website at lymphoma.org if you're on your phone. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options in clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. We offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest in lymphoma information. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. Finally, we've launched our COVID-19 Learning Center to support lymphoma patients and caregivers through this challenging time. Please visit our Learning Center for access to webinars, articles, and other resources specific to COVID-19. I really hope you'll take advantage of some of the great resources and services that LRF provides. If you have questions regarding what you heard about today, or if you need information about relevant treatment options and supportive care resources, you can reach out to the LRF through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. We have a wonderful program planned for you today, and I'm honored to introduce Dr. Sarah Rutherford. Dr. Rutherford is an assistant professor of medicine in the Division of Hematology Oncology at Weill Cornell Medicine. In addition, she has served as an expert speaker on numerous patient and professional programs for LRF. Thank you so much for speaking today, Dr. Rutherford. I'll now turn the talk over to you.
Thank you so much, Jessie. I really appreciate this opportunity to speak to you all today about follicular lymphoma. I'm really excited because there have been a number of new drugs and therapies approved for this disease just in the last year or two, and the management is really changing quickly over time to be more specific to targeting lymphoma cells, and that's often associated with less side effects. So have a great message of optimism today with all the treatments we have to offer. I'm first going to start by giving you all some background on follicular lymphoma. Then I'm going to go through the management of newly diagnosed patients, emerging treatment options, which I just referred to, and then at the end we'll do a question and answer session. So I already see some great questions coming through on the chat, and I look forward to answering as many as I can afterwards. So, make sure to remember any questions, and I'm happy to go over them all at the end. I'll start with an overview of follicular lymphoma. So first, lymphomas in general can arise from lymphocytes, which is a type of white blood cell. Those white blood cells normally help to fight infections, but sometimes there are errors that happen in their development. So if you focus on the right-hand side of the slide here, in the stage of the development of lymphocytes, you can see that there are B lymphocytes and T lymphocytes, two different types. Follicular lymphoma is a B cell lymphoma. And so if there's a problem in the development of the lymphocyte at this point, then it can turn into a lymphoma. when lymphomas are diagnosed, they're often found throughout the body. So you can see all of the different lymph node chains here, from the neck all the way down to the pelvis and even behind the knee. And so it's very different than some other types of cancers where when we see it spread throughout the body, that makes the prognosis less favorable. People usually are found to have lymphomas in more than one place, so I'm expecting that when I do imaging tests to assess the stage of the lymphoma. But because lymphomas are very responsive to treatment, the treatment can travel to wherever the disease is and help to get it under control. I do have a picture here of bone marrow. So about half of patients with follicular lymphoma have bone marrow involvement. And we'll talk a little bit more about that later. But again, the treatments that we give go to all these different places and help to control the lymphoma regardless of where they are. This is a slide showing the incidence of non-Hodgkin lymphoma. So when I first meet patients, I make the distinction between Hodgkin versus non-Hodgkin. Hodgkin is really about one type of disease, whereas non-Hodgkin is over 80 different types of diseases. And it is, as a whole, the fifth most common type of cancer in the U.S. There were an estimate of about 80,000 cases this year will be diagnosed of all different types of non-Hodgkin lymphoma. The 5-year survival is very high, and there are a number of patients living with non-Hodgkin lymphoma, particularly types like follicular lymphoma, 750,000 or so. And I just wanted to give you an overview of different subtypes of lymphoma just to put this in context. So one of the ways we think of the different types of non-Hodgkin lymphoma are indolent or slow-growing versus aggressive or fast-growing. So follicular lymphoma is the most common of the slow-growing lymphomas. Diffuse large B-cell is the most common of the fast-growing lymphomas, and then you can see some other lymphoma types listed here. And then I have a breakdown on the next slide of distribution of the different types of non-Hodgkin lymphoma. So you can see about 22%, that's the upper right, kind of like from 12 o'clock to 2 o'clock on the, if this were a clock, on the pie chart here that shows that about a quarter of patients with non-Hodgkin lymphoma have follicular lymphoma. And one good aspect of that is that we're able to do large clinical trials in this patient population. So a lot of the treatments that we have approved have been approved on the basis of clinical trials with patients with follicular lymphoma. And I'll go over some of the details of that coming up. So again, this is the most common type of slow-growing lymphoma. The median age of diagnosis is 60, so a number of patients are older with this diagnosis, and that certainly is a factor in terms of if patients have other diseases or other issues as they get older, that may factor into what treatment we recommend. I do want to mention, though, I do have a number of patients who are younger with this diagnosis, even in their 20s and 30s, so it really does affect a wide age range. It's generally considered incurable, and I think of it more like a chronic disease, but I don't view that as a bad aspect. It's really more that it's something that we will manage basically with the lowest toxicity treatment that we can give to get the disease under control, and it's really managed more like a chronic disease. So it will often require different treatments over time, but hopefully patients will have long periods of time where they don't need any treatment while they have the course of this. And most people live with this disease for many years. Many people live their entire normal lifespan, and we control the disease if it becomes active and get it into remission so that they can go on to basically live the best quality of life for the most number of years possible. And really what goes hand in hand in this is that there's been studies looking at treating people very aggressively with multi-agent chemotherapy, for example, and this does not improve overall survival to do that early on. So sometimes when I meet people there, this can be a difficult concept to get used to, that you have a cancer type, but that we want to monitor it, for example, and not do any treatment or give you, very mild treatment. But I just really want to emphasize that even if we give people very strong, side effect chemotherapy that has side effects, that would not result in an overall survival being elongated. So it's really like a marathon. That's another analogy I often make, where we really want to save our drugs, our options for times when we really need them. We're going to be going for the goal of having our patients live for their normal entire lifespan, and so we want to really be smart about when we use certain drugs, and as you'll see, there are more and more of them available, which is really good news for all of you all and all the other people that are facing this diagnosis. And again, the goal of management is to keep patients feeling as well as possible for as long as possible. Now, I wanted to mention how patients with follicular lymphoma, you'll see that I have abbreviated it as FL throughout the presentation. That's what we often call it. So probably the most common presentation that I see is someone coming in with an enlarged lymph node, either found on exam by their doctor. They may have noticed, for example, swelling in their neck, and they come to their doctor and get evaluated. They may be having imaging for some other reason. So I, for example, have a patient who years ago had a kidney stone and had a CT scan done that showed some enlarged lymph nodes. And that patient, that's 6 years ago, is still doing very well without any treatment. And I see the same, for example, in women who have mammograms. Sometimes they are found to have lymph nodes under the arm. They don't have any symptoms at all. And those are excellent candidates for the what we call active surveillance approach, who may not require any treatment after initial diagnosis. Another way that some people present is with abnormal blood counts. So that primarily would be low blood counts. Sometimes it can mean a high white blood count, but often people could have a low hemoglobin, which is anemia, or low platelet count, and that might prompt some workup, a referral to hematologists and workup to ultimately discover a diagnosis of follicular lymphoma. And that usually happens if the lymphoma is in the bone marrow. The bone marrow is where blood cells are made, and so if there are follicular lymphoma cells crowding into the bone marrow, it may make it so that the other types of blood cells, red blood cells and platelets, may not be able to be made normally, and then they are manifest as low blood counts. Another way that people sometimes present is with weight loss, and one reason for that may be due to a large spleen. A spleen is an organ that can be involved in lymphomas. It has lymph tissue and on the left upper side of your abdomen. And when people have a large spleen, sometimes it pushes on the stomach and makes them feel full easily. We call that early satiety. And so sometimes people lose weight. And sometimes they're not even aware of it, but they're not eating as much because of that. And I have had it happen where people have biopsies for other reasons, and I've really alluded to this from the standpoint of breast workup for breast cancer. Sometimes shows lymph nodes that are biopsied and are found to be lymphoma. Sometimes endoscopy findings, so lymphoma can be found in the GI tract. So sometimes we get diagnoses that are not necessarily expected, but that are found from biopsies of the GI tract when that test is being done as normal surveillance for people that are 50 and older, for example, in a colonoscopy. And lymphoma can impact the skin, and so sometimes the skin biopsies will lead to a diagnosis of lymphoma. And then lastly, sometimes follicular lymphomas can congregate in fluid cavities in the body. So, for example, around the lungs, there's some fluid there that is called pleural fluid. So occasionally, and this is pretty uncommon, but occasionally we can have patients presenting with shortness of breath or swelling in their abdomen, for example, due to fluid that's involved in lymphoma. The workup of suspected follicular lymphoma would certainly include blood work. People often ask me if this is something that can be detected in the blood. That is something that's being researched thoroughly now to try to come up with techniques to diagnose these diseases in the blood, different types of lymphoma. But there also are a number of other blood tests that we do. For example, there's something called a monoclonal protein that can be associated with some lymphoma types, and so we will look for that. We often do hepatitis and HIV serologies because there is an association with hepatitis and HIV with some lymphoma types. And also one of the mainstays of treatment for follicular lymphoma is rituximab, which can cause reactivation of hepatitis B in someone who's been exposed to it before. So it's very important that we check those tests. We always check your kidney and liver function, and a blood test called LDH, or lactate dehydrogenase, that helps us get a sense of how much lymphoma is there in your body. We prefer to do PET CT scans if possible. If occasionally we do CT without the PET portion. That is really to help us know exactly where the disease is. The PET CT is helpful because it not only gives us a measure of the size of lymph nodes with the CT portion, but the PET portion gives us an indication of the activity level. And I do want to mention that it is, while rare, it is possible that a slower growing lymphoma like follicular lymphoma can transform into a faster growing lymphoma. And so we have to be aware at all times of that possibility, and one of the reasons we do PET CT scans when we can is that can help us get a sense of how fast growing the cells are. And what we usually want to do to make the diagnosis is to biopsy the place we see on a PET scan that is the most active looking and most easily accessible. So we try, if we can avoid it. We don't want to do like invasive surgical biopsies in the abdomen. Sometimes that's the only way to get the diagnosis, which, obviously making the right diagnosis, now that you know that there are so many different types of lymphoma, is the most important part of the process. But we, for example, if someone has a lymph node in their neck or under their arm or in their groin area that's palpable that we could feel, those are the best places for us to go for a biopsy because it's the least invasive approach. And what we prefer, if possible, is something called an excisional biopsy, where the entire lymph node is taken out or a large amount of the lymph node is taken out, so that we really have plenty of tissue. And that really is our pathologists who look under the microscope and make diagnoses based on the way it looks, and also based on a number of tests, including staining for certain proteins that are characteristic of follicular lymphoma. I do want to mention that I'm actually a strong proponent of trying to avoid bone marrow biopsies if they're not going to change management of the disease. So in the past, they have been required as part of the workup for certain types of lymphoma, but really the evidence is growing that supports that follicular lymphoma management will not be changed whether or not there is bone marrow involvement. And actually, even if you look in the NCCN guidelines, which is a National Cancer Network guideline, bone marrow biopsy is really not required for diagnosis of follicular lymphoma. The exception would be, in particular, is if patients have low blood counts that I mentioned before, if you really want to make sure that that's the reason for the low blood counts. So that might be one reason. And at this point, most clinical trials require bone marrow biopsies to be done at baseline, and then to prove that the patient's in a complete response after they've received clinical trial treatment. And I'm actually have been doing a lot of research to show that really is not necessary. And I have another paper I'm actually working on right now to try to make this a bigger, widely accepted type strategy to avoid bone marrow biopsies for most patients with newly diagnosed follicular lymphoma. So just briefly wanted to mention that there's tumor grading in follicular lymphoma. So this is not stage. Stage is made based on where the disease is in the body, but tumor grade is actually what it looks like under the microscope. And so you don't need to focus on the top box, but the point really is that there's 3 grades, and grade 1 and 2 tend to be slower growing. So you can see here at the bottom, this would be what the different cells would look like. And in general, grade 3 follicular lymphoma cells tend to be a little bit larger. In practice now, the pathologist will actually combine grade 1 and 2 together. So they'll report it as either grade 1 to 2 or grade 3. And grade 3 is usually split into 3A or 3B. And 3B is actually thought to be more like a faster growing lymphoma, diffuse large B-cell lymphoma, so it's usually treated more like diffuse large B-cell lymphoma. Grade 3A, is something to really talk about with your doctor. If you have that grade, then, sometimes we may decide to treat it more aggressively, but I have often found that people respond very well to the standard rituximab-based therapy, which I'll go over in just a minute, even in the grade 3 situation. But I just wanted you to be aware of the different grades of the disease. management of newly diagnosed patients we'll move on to. So the first question really is treatment indicated? I have a number of patients who are doing very well without any symptoms related to this disease, and so those patients we usually monitor without any treatment. And I would say certainly in the time of COVID, particularly last year when, before we had the vaccine and we still didn't know a lot about the virus, we would try to minimize treatment when we could, just because we didn't want to do anything to make patients more immunocompromised. But certainly if people have symptoms that are related to the disease, so for example, pain, with these lymph nodes swelling, sometimes people don't have any discomfort, but if it's pretty large, it may be causing some pain, maybe impacting the walking or your functioning in general. So that would be an indication. If patients have weight loss due to, for example, their spleen being enlarged, as I mentioned, and they're not eating as much, or if they have shortness of breath. I would say fatigue is actually one of the most common symptoms, and that can be hard sometimes to tease out if the fatigue is really from the lymphoma or some other medical problem. So we really work through that carefully together with patients to make our best assessment of the cause of fatigue in a patient with follicular lymphoma. There is something called the GELF criteria, which gives a number of different sort of sizes and other indications of why you may decide to start treatment in follicular lymphoma. So in general, if people have what is considered a large volume of disease, so large bulky lymph nodes, that might be a reason why we want to consider treatment. And then I've mentioned a couple times now, if low blood counts are thought to be related to follicular lymphoma, that would be another reason to start treatment. So if the answers to these above questions are no, we typically do what's called the active surveillance approach. I'll go over both of these strategies on the next page. And if the answer is yes, then we would consider treatment. One option is single agent rituximab, the monoclonal antibody that's really been a mainstay of B-cell lymphoma treatments for over 20 years now. We can give rituximab or a newer version of a monoclonal antibody against CD20 called obinutuzumab plus chemotherapy. And then there's a third option now, which is not technically FDA approved, but there is data to support giving rituximab with an oral drug called lenalidomide that is FDA approved for some other lymphoma types and for follicular lymphoma in the second or greater line setting. Active surveillance is done when patients have no symptoms or low blood counts due to the disease. And we monitor with blood work and physical exam every 3 months. We sometimes can space that out if patients have been very stable over a couple of years. Imaging is indicated if patients develop symptoms. I do want to mention another part of the management that I'm an advocate for is to not do scans regularly unless patients really have an indication for them, because we are expecting people to live many, many years with this disease, and we want to minimize the radiation exposure. And there are also some other downsides of doing frequent scans. It can cause anxiety, for example, in patients. So really there's a lot of literature that looked into this over the years, and the vast majority of the literature supports that if patients are followed closely by their physicians with exams, with lab work, and they let their doctor know if there's something different in between their visits, that is just as good as doing scans frequently. So I really tend to watch very closely and reserve doing scans for when there's some indication that the patient might be having a lymphoma progress. And so I've highlighted at the bottom, the key is really that the patient and doctor keep in really close touch in between visits. And I tell my patients to call me no matter what is going on. I want to know if there's, maybe it's completely unrelated, but I like to know if there's something new, some new symptom or issue, and we can work together and decide if that is going to merit us to look back into, doing a scan or other workup to assess if the lymphoma is growing. The first-line treatment of follicular lymphoma really is tailored to the individual person. So what we try to do when possible is rituximab for 4 weekly treatments. So again, rituximab is a monoclonal antibody. It's a targeted therapy against CD20, which is a B-cell marker, a protein on the surface of B-cell lymphomas, including follicular lymphoma. It's not a chemotherapy. It does not cause hair loss. It's very well tolerated. The main side effect that people experience is it can cause a shaking, chill-like reaction the first time they get it. We give Benadryl, steroids, and Tylenol to try to avoid that. Nurses who give this drug are very used to dealing with this. If that type of reaction happens, they stop the therapy. They give the patient some time and maybe give them some more of these medicines that I mentioned and then restart it at a lower rate. Usually this issue does not happen on the second, third, and fourth dose. And there actually is a formulation now available in an injection, so it's typically given by infusion. The first treatment usually takes on the order of 4 to 6 hours. Subsequent treatments through infusion can be given over about an hour and a half. But some people prefer to get an injection version, which is like a shot that's given. So that's an option too. There are a number actually of other monoclonal antibodies against CD20, but one that's approved for follicular lymphoma is called obinutuzumab. And that is actually only approved to be given concomitantly with chemotherapy. So it's not a drug we would give first line by itself. Just to go back to the rituximab as a single agent, I want to mention the times we would use that is if we think that someone needs treatment, but they're not particularly having very aggressive symptoms. They may have some enlarged lymph nodes, but they feel pretty well. One aspect of rituximab is that it can take some weeks before it really kicks in, and sometimes a couple months or longer before its full effect is known. So if someone is very symptomatic from the disease, for example, if they have lymphoma in the fluid around the lungs and they're short of breath, or there's some other reason why we feel they really need a response very quickly, then we will often incorporate chemotherapy with either rituximab or the newer monoclonal antibody against CD20 called obinutuzumab. And again, we try to avoid chemotherapy when we can, but there are certain circumstances that it's very clear that patients need to get the disease under control quickly. So the most common chemotherapy that we use is called bendamustine, and this is given for 2 days in a row. We usually give it every 4 weeks for 6 total cycles. So it's 6 months of treatment. It's usually very well tolerated. It can and does lower blood counts. And so it does put people more at risk for infections, particularly like right middle point in between two cycles. That's when the blood counts are at the lowest. We use an injection, usually called pegfilgrastim. There's some other names of that drug that helps to boost the white blood cell count in between treatment. And we typically would do another PET scan after about 2 cycles of treatment to assess the response to make sure that the treatment is working. Although we usually know because patients are usually feeling better quickly after starting treatment, and then that is continued for 6 cycles. And then the third first-line treatment that I've mentioned already that's not technically FDA approved, but it is an option, is rituximab plus lenalidomide. Lenalidomide is an oral drug. It was originally approved for myeloma years ago, so hematologists have a lot of experience with it. It's given 3 weeks on and then 1 week off, and the exact time duration can be variable depending on the patient, but it would be usually on the order of 1 year, sometimes 2 years. So one disadvantage of this treatment is that it lasts longer. I'd say that it tends to still cause some side effects, but it's sort of spread out over time rather than sort of more side effects in a shorter time period, which you would get with the chemotherapy-based approach. But both of these strategies, the chemotherapy-based and lenalidomide-based, are very manageable. We have a lot of ways to be proactive about minimizing side effects of them. But I would say the most common and concerning side effects are increased infection risk, so we would be watching very closely for that. And we want you to let us know if you have any signs of infection in between treatments, fevers, chills, or other signs, sore throat, cough, et cetera, so that we can put you on antibiotics and watch that very closely. Monitoring after completing first-line treatment, we would usually do a PET CT scan about 6 weeks after treatment, and that would go for either of the approach I mentioned in the last slide. And 3 months is really the key time frame where we will continue to watch carefully. That would be either if we're not doing treatment, or if we do treatment, we'll watch you carefully with blood work and physical exams every 3 months. And again, I think it's very crucial that patients stay in close touch with their physicians if they develop any new symptoms or issues in between visits. Imaging, again, like I said before, would be indicated if patients develop new symptoms or if there's some sort of abnormality on exam that's detected at a visit. But I usually, and I think a lot of oncologists who treat follicular lymphoma do not continue to do imaging at regular intervals because patients are going to be living with this disease for many, many years, and we don't want to continue to subject you to more scans than are necessary. Now, if we do at some point suspect that the disease is recurrent, we would want to repeat the biopsy. So we would want to first repeat a PET scan, and then the same tactic that I mentioned before we would use again, which is to we try to biopsy the most active looking site that's the most easily accessible area. We mainly want to make sure that we're dealing with lymphoma. So occasionally we've had patients, and given that you're going to be living for many, many years, occasionally patients have developed other cancers than lymphoma. And then secondly, we want to make sure that it's still follicular lymphoma with the same characteristics that it had when you were initially diagnosed. Now, the exciting part are all the emerging treatment options. So again, the management of relapsed disease would be depending on timing and type of prior therapy. So, for example, if someone got rituximab before, but it's been many years since they got it, say 3 or 4 years, then we can certainly use it again. It would likely be efficacious again. In contrast, if someone got treated and then 6 months later the lymphoma starts acting up, we would want to do something different than rituximab because we'd be concerned that that wasn't going to be sufficient. Patient performance status and comorbidities are a factor. So in particular, this is not always age related, as you all know, that there's a wide variety. I mean, I have patients who are in their 80s and 90s who are functioning as if they were in their 70s, and some younger people have other diseases that make it a little bit more complicated to treat their lymphomas. But I would say with some of the older patients I have in their 90s, I would try to give them the mildest treatment, particularly for them. So rituximab, I might be more likely to give rituximab a second time, even if there hasn't been a lot of time that's passed, just with the idea that I don't want to make them sicker. I want to keep them feeling as well as possible. And I've definitely had some success with retreating with rituximab in many patients. So if someone has relapsed and they did not get chemotherapy before, certainly that would be a very reasonable second-line strategy. So if they've gotten rituximab and then, say, 2 years later the disease comes back, we could consider giving them rituximab plus bendamustine, which is the chemotherapy-based regimen I mentioned before. We could consider giving them obinutuzumab plus bendamustine. And then the lenalidomide, the oral drug I mentioned, with either of those drugs would be another option. So what I would typically say is that most doctors would use rituximab as a single agent if they can initially, if that will, we think that will be adequate to control the disease. Second line would usually be bendamustine-based chemotherapy, and third line is usually lenalidomide-based treatment. But that being said, every patient is different, and the treatment it really needs to be tailored to each individual's exact situation. There's another category of drugs. So I'm going to talk about 3 FDA-approved options from here, and then I'm going to talk about a 4th treatment that's in clinical trials that's very exciting. So there's a type of drug called PI3 kinase inhibitors that have been around for a number of years now, and there have been new ones approved. So the most recent one was just approved this year. And the goal has been to try to make these better tolerated. So there's 3 of these drugs that are indicated for people who've already received 2 lines of therapy. So most doctors would use this if the patient had already gotten rituximab, chemotherapy, such as bendamustine, lenalidomide. This would probably be the 4th option historically. Now that's changing as we get some new options available. So the original one to be approved was idelalisib, and that's oral, given twice daily. There's one called copanlisib, which is given by Zane weekly. I think a lot of people prefer to take oral drugs at home, but there are some patients who, for various reasons, prefer to come in and get treated in our infusion center. And then duvelisib was the most recently approved until umbralisib, which is a newer one that was just approved earlier this year, and is technically approved after 3+ lines of therapy. These drugs, they're, just to be completely open with you all, have had some side effects traditionally that have been probably what led them to not have been widely used, as lenalidomide, for example. So they can cause decrease in blood counts. They can impact the liver function. This is not every single one of them, and the newer ones have worked to try to make them better tolerated, and I think they are. They have caused some lung issues and inflammation of the colon as well. But I certainly think that they're very efficacious drugs. So, when we do use them, I think we just have to be very cautious about monitoring. So I tell patients to please keep me posted about any respiratory issues, any diarrhea. Again, just as with any treatment I give, any signs or symptoms of infection. And then in particular, copanlisib, the IV one, does have some impact on blood sugar and blood pressure. So for someone who has diabetes, for example, that's probably not the best drug. However, that drug doesn't tend to cause some of the other lung and GI-related issues. So I think this is a great class of drugs in terms of efficacy. I still would probably reach for some of the other drugs first, but it's certainly a good option to have available. And in most patients, we've been able to find a way to manage any side effects and have them continue on these drugs if we start them. The next treatment is actually was approved in the last year, and it's called tazemetostat. And it's called an EZH2 inhibitor. So this is also an oral drug. There's only one in this class that's approved. There have been some other ones studied in the past and some clinical trials ongoing. So you'll probably hear more about this type of drug as we go forward in time. So there's something called EZH2 mutation that can happen in the development of B cells. So if you remember back to one of my early slides when I was talking about if there's an error in the development of the B cells, that can develop into a follicular lymphoma. So one of these mutations that can happen has been discovered to be this EZH2, and actually a lot of some research on this has been done at Cornell with some of my colleagues. And it leads to the inability of the B cells to complete their normal development. So this happens in about 20% of cases of follicular lymphoma. This has not been a test that has been routinely done. There is now a commercially available test. We wouldn't normally do it early on in the course of treatment, for example, in a newly diagnosed patient, because this treatment is not indicated in patients who have newly diagnosed disease. But if someone has a relapsed disease, it would be a time when you would consider sending a blood test for it. Now, that being said, it actually does have effect in patients who don't have those mutations. So we really could use it in any patient with follicular lymphoma. It's given twice daily in a pill form. And again, the best responses are in those 20% of patients who have the EZH2 mutation, but also effective in those without. And I think we're still learning about this drug. It's been, I believe it's just about a year ago when it was FDA approved. One of the good aspects of this drug is that it's thought to be very well tolerated. So it does cause some fatigue, nausea, anemia, or low red blood cells, but overall, it's something that people don't tend to have that many side effects. I think we're still working out the exact efficacy. The clinical trial that studied it was a small trial, so I think it's one of these drugs where I don't see a lot of downside to using it, but it may not be as effective, for example, as the last class of drugs I talked about, the PI3 kinase inhibitor. So that certainly an option, and one that we'll keep gathering more information over time as more patients get this given to them as treatment. Now, the next type of treatment, this is the last one that's recently FDA approved that you may have heard about in the press, and this is really exciting. It's called CAR T cell, or chimeric antigen receptor T cells. Now, this has been approved for a couple years now in diffuse large B-cell lymphoma, the most common of the fast-growing lymphomas. And so we have a lot of experience with it. It's often given by the same doctors who do stem cell transplant. That's not a topic that I had planned to cover, although if people have questions about that, we can talk about it later in the question and answer session. But essentially what happens is we have blood collection done. So if you look at the bottom where you see this person at the bottom and then go along in clockwise fashion, T cells are isolated from the patient, so blood collection is done. There are a number of companies that make these drugs. At this point, there's only one FDA-approved version for follicular lymphoma. It usually takes on the order of 2 to 3 weeks. The blood is sent to the company. They manufacture the person's T cells in a way that helps for them to better recognize cancer cells. So this is really an immunotherapy type approach They grow these T cells, and then eventually, about 3 weeks later, the T cells are infused back into the patient, and that helps the lymphoma to be fought better than the patient's own T cells could have done without that support. So it's called Axi-cell, is the type of product that was approved for follicular lymphoma just in the last few months. And it's approved after 2 or more lines of therapy. So as you can imagine, this is really going to change the paradigm of treatment for follicular lymphoma. So this would be someone who may have had chemotherapy or rituximab-based treatment, may have had lenalidomide. They may not have had lenalidomide, but they would be a candidate fairly early on in their course. We're still learning how long this will last, the effect will last. Again, this isn't viewed as a curable disease. I think that's going to be one of the big questions to answer in the coming years is how long of an effect do the CAR T cells have? So what I would say, this type of treatment is one that's it does have some notable toxicities, and so you would really want to make sure that a patient has a good performance status, doesn't have a lot of comorbidities. Like, this is not something that I would want to give to someone in their 90s who has a lot of other medical problems, because I would be concerned that the toxicities would be greater than the benefit. But certainly for younger patients, and again, like I said before, age is really not the best assessment of people's performance status in general, and particularly in lymphoma. So I've had some patients with diffuse large B-cell lymphoma in their 80s get this type of treatment and tolerate it very well. But certainly it just requires a very close discussion of potential side effects, because we know that some of the other options for follicular lymphoma would be better tolerated than this. But it's possible that we may get more time out of this, meaning that this could keep the disease under control for longer. And so, again, we don't know the answer to a lot of these questions because this was just approved, and the relatively small number of patients were treated on the clinical trial that led to its approval. But I'm very, very excited to have this as an option for patients. It tends to be administered in the hospital setting. Some of the CAR T-cell products can be administered in an outpatient setting, or maybe eventually will be, but that is one aspect where none of the other treatments I mentioned are given in the hospital. And there are a couple of side effects. One is called cytokine release syndrome. This has a clinical picture like sepsis, which can be a severe syndrome of low blood pressure and fevers that sometimes requires a stay in the intensive care unit. Most of these issues are usually reversible, but it is a very serious type of therapy to give, and people really need to understand the potential side effects before they go through with them. The other notable toxicity is neurologic side effects. So sometimes people have, for example, some confusion. Usually this is reversible if it happens, but we definitely do very thorough investigations like MRIs of the brain, and we have our patients see neurologists for a full exam before we give this type of therapy. So a very exciting therapy. I think it still is going to require a lot of investigation of patients, what we call in the real world versus the clinical trial setting, where we see how people are responding to it, and in terms of efficacy and side effects. But it's a great option that is a very promising therapy for our patients. And then the last one I want to mention is something called bispecific antibodies, and this is similar to CAR T in that it helps basically make the T cells respond better to the cancer. So these have 2 different targets. I've mentioned with rituximab and obinutuzumab that they bind to CD20 on the B cells. So these bispecific antibodies bind to both B cells and T cells. So unlike CAR T, they don't require a preparation time of blood being collected from a patient. They're actually what's called off the shelf, meaning that they're a product that's purchased and given to a patient and not specifically manufactured for that one patient, which means that it actually is available much more quickly. And one of the downsides to the CAR T is it does take a few weeks to make, and so sometimes patients may be symptomatic and need treatment sooner. That tends to apply more to the aggressive lymphomas, but it is a important point here. So there are 4 different ones of these that are being studied right now. And I put the names here. You don't need to remember them. Obviously, they're challenging words to say. But I think this is going to be a really good option, too, in addition to CAR-T, and maybe safer than CAR-T, because they tend to have less of those toxicities like the cytokine release syndrome and neurologic toxicity that I mentioned. Many of them can be given as an outpatient. At least 1 or 2 of them, I think, have an injection form. Like the other ones are intravenous, but the 2 of them can be given by shot, which is a faster form. So I think this is something to watch, and it'll be interesting to see, how this plays out compared to CAR-T. And it may be because they have a better side effect profile that may be preferred over CAR-T, particularly for patients with other medical problems and older patients as well. So, I just want to, again, give you such a message of optimism. I am just thrilled with all of these drugs that are available now and more to come. And I think it's just going to keep being like that more and more, that our disease management of follicular lymphoma is really going to become more and more specific to where we're able to target the lymphoma cells and not have as many side effects as we've traditionally had with some of the chemotherapy-based approaches. Thank you so much for your attention, and we're going to do the question and answer session. So I think we have about 15 minutes. I know some people have already asked some questions. I think Jesse is going to facilitate the questions, and then I'll do my best to answer them.
Great. Thank you so much, Dr. Rutherford. That was a really great, wonderful overview, and a really just kind of hopeful outlook for the future, like you said, with all those emerging treatments. So we'll now begin our Q&A portion. We have a lot of people on the call today and a lot of questions coming in. So I know we won't be able to get to everyone's question, but we will do our best to get it to a good handful of them. And if you have any questions after the program, you can always reach out to our LRF helpline at 800-500-9976 or reach out to your doctor directly. But in the meantime, I will start with our first question, which is, have any studies been done linking diet to follicular lymphoma outcomes?
I think that's an excellent question. And my sense in general, and I usually tell my patients that normal, healthy habits like diet, well-balanced diet and exercise, I think people do better with lymphoma treatment, like those who are undergoing treatment who do eat a healthy, well-balanced diet, as well as those who exercise regularly tend to tolerate treatment better. I'm not aware of any particular studies focusing on diet and follicular lymphoma outcomes, but for example, we have nutritionists that works with us. I usually refer all patients who are interested in to meet with that person, and I do think healthy eating habits and exercise are very helpful for patients as much as they can do that.
Thank you. Our next question is, this person writes that they see many statements about COVID risks, and they always say if you are immunocompromised, and this person, for example, has indolent follicular lymphoma that was treated with radiation therapy, and they ask, are they considered immunocompromised? And maybe you could just describe to everyone what that means for kind of the general kind of cancer oncology.
Yeah, that's a great question. Yeah, that's a great question. So I think in general, there's sort of varying levels of immunocompromised state. So I would think in general that anyone who has a diagnosis of follicular lymphoma or other lymphoma may have some immunocompromised part of their immune system because of having the disease underlying. If you're in a remission, you're less likely to have that. And I think if you only received radiation treatment, you're probably sort of at the lowest end in terms of immunocompromised state. Those who would be at the highest are ones who are actually getting chemotherapy-based treatment or some of these other oral therapies ongoing, because you have some other factors there where your blood counts may be low. You may be at risk for bacterial infections as well because of low blood counts. So in general, I'm still advocating that my patients be very cautious We still think the vaccine may not be as effective in patients who have lymphoma than they would be in someone who doesn't have lymphoma, particularly those who are undergoing treatment now or recently finished treatment. And so for example, I'm advocating for people to still wear masks inside and to try to really be careful with who they're around in terms of, trying to minimize being around anyone who might be symptomatic. But in general, for the patient who asked that question, I think, probably within the scheme of immunocompromised, you're probably like the least immunocompromised of a patient that has this disease.
Great. Thank you, Dr. Rutherford. Our next question is a question about chemo drugs and the side effects. They asked if there has been research to show how chemotherapy drugs can affect patients with psychiatric conditions such as anxiety and depression.
So I think this is a tough question to answer because I think that just the diagnosis itself can cause anxiety and depression. Obviously, even though I have been very optimistic, it's still, the reality is that some of you have been diagnosed with a cancer that you're going to live with for the rest of your life. I mean, that would be anxiety provoking for anyone to have to deal with. So, I think just the diagnosis itself is a factor to maybe exacerbating issues with people who already may have anxiety, depression, or for those who have never had it before, but now they feel down or anxious because of this diagnosis. I'm not aware of any specific reasons why treatment, chemotherapy or other treatments would trigger more of in itself, but I certainly don't think that there have been studies. I'm not aware of any studies specifically looking at that. But I do want to say that I know that LRF has some resources that can help patients if they're feeling anxious or depressed, and I would imagine that your cancer centers do have that type of support for you as well. And I know we have a lot of support at our center at Cornell, and I just urge you to talk to your doctor about it. I think sometimes we try to ask patients about these types of issues, but you really do need to let us know if you do feel anxious or depressed, because we want to do everything we can to help you feel better and supported during this time, and really to let you know that it's normal to feel that way. So please reach out to your doctors, and like I said, I think the LRF has some resources that could help you too if you're experiencing these types of issues.
Yeah, definitely. Definitely use our helpline as a resource if you have any questions or would like any referral. But like Dr. Rutherford said, I think your cancer center is also a great resource as well. We've had a couple questions about transformation. This person in particular said that they have indolent follicular lymphoma. And number one, asked if there are other types of follicular lymphoma, and also statistically, how often does it mutate into another form of cancer, like DLBCL?
So I want to mention the term indolent. Often we use that means slow growing, and so follicular lymphoma by definition is an indolent lymphoma. But it may be that this person particularly has the grade 1 to 2, the lower grade lymphoma. So, I think it's important to be aware of the possibility of transformation, but it is a low risk. So I don't want people to feel overly anxious about it. It is a rare occurrence, but it is something that your doctors need to be aware of. And you too, that you need, so the types of symptoms to watch out for would be more of what we call B symptoms, which are fevers, chills, night sweats. That can go along with indolent or slow-growing lymphomas like follicular lymphoma, but they're more characteristic of the faster-growing lymphomas. Or if you're just feeling, if symptoms kind of happen suddenly, the faster-growing lymphomas tend to cause more symptoms and they happen more quickly. So I would just really urge you to talk to your doctor about that if you have anything like that. Be aware of it, but don't let it, if as much as you can. I know it's easier said than done, but try not to let it consume you, because it's a very low risk overall. It's just something we know can happen, and so we want to, we want to watch for it. But realistically, like the majority of you that I'm speaking with are not going to have that happen. And if it does happen, we have very good treatments for it. The chemotherapy that we give is a very standard treatment that works well for that disease, and it can be managed. So if that were to happen, there's good strategies for it. So I think that's my best answer to that question. We can move on to the next one.
Great, thank you. Someone asked if MRIs are as accurate for diagnosis as PET scans, and if not, why is that?
So the reason we like the PET scan is because it gives us this activity level that's called standardized uptake value in addition to the size of lymph nodes and other organs. MRI would be comparable to CT, where they both really focus on the size. There is a type of test called a PET MRI. I've had a few patients request it. Usually, insurances aren't always approving it. Maybe that'll be a way more of the future, but at this point, PET CT is really the standard. And I don't think, I would certainly prefer a PET CT over an MRI by itself, because I can get the activity level indication as well. And then, I just want to make the point, in addition to that giving me a good baseline, it's also important to see when people have responded, when they're getting a follow-up PET scan after treatment, to really assess how well the treatment has worked. That PET scan part is very important for that.
Great, thank you. This person asked, after one progresses from R-CHOP, BR, and CAR-T, what is left to try?
Okay, so now we have lots of options for this. So that would be all of the oral drugs I mentioned. So lenalidomide is one of them. And I think your doctor could decide, if you hadn't gotten obinutuzumab before, that I would give lenalidomide with obinutuzumab. The PI3 kinase inhibitors, the tazemetostat, the newer EZH2 inhibitor drug. And then, another thing I haven't really mentioned that much, but clinical trials are a great option, particularly for follicular lymphoma, because, one issue with clinical trials is sometimes they have some requirements that make it take a couple weeks. They may delay you starting treatment compared to just a standard of care type treatment. But I would urge you, if you have that option, to look into them, because sometimes you can get access to drugs that are maybe more effective than the FDA-approved versions, and they're covered through clinical trials, so you wouldn't have to pay for them. And I think that, again, particularly in follicular lymphoma, it's a really good disease to try to get on trials, particularly if you're someone who's received a lot of standard of care treatments already.
Our next question is, with all the newer drugs for treating follicular lymphoma, why is R-CHOP still being used since it has so many side effects?
So I didn't really talk about R-CHOP that much. We don't tend to use it that much in my center for follicular lymphoma. The time I would use it, for example, would be as if I suspect that someone may have actually had transformation to diffuse large B-cell lymphoma, but that I can't prove it. For example, they might have a very difficult to access lymph node that I don't want to put them through a very invasive surgery. So, to me, and I think, this is another point I want to make, that, one aspect is, because there's so many new therapies, that you may want to consider at some point getting a second opinion at an academic center with someone who only focuses on lymphoma. Not that you necessarily have to transfer your care to that person, but that I think those of us who really focus, like all I do all day is take care of patients with lymphoma and do research related to lymphoma. So I probably have more experience with some of these newer drugs than another doctor that sees patients with all different types of cancers. So I would, that's something that, we're always happy to work. I love working with other doctors locally. I want to make people, have the easiest access to treatment. And if I'm going to offer the same treatment that you would get with your doctor close to home, then I can help guide the management, but that you could still get it with that doctor at home. So, so that being said, I don't use R-CHOP that much in this disease, because I think we do have a lot of better therapies. R-CHOP does work, but it does have a lot of toxicity compared to some of the other options. So, so I certainly would consider some, milder approaches if I can.
Great, thank you. So I asked, what is the best practice recommendation for getting scans after your treatment has finished?
So typically, most doctors would do one about 6 to 8 weeks after you finish the treatment to assess your response. And as I mentioned a couple times during the talk, There have been a lot of studies looking into this for different types of lymphoma, what we call surveillance scanning. And that would mean someone getting scans, for example, every 6 months ongoing. And the vast majority of research shows that doing surveillance scanning does not improve someone's overall survival. And so what we tend to do in our center and in a lot of other centers is really tailor the management and the surveillance to the exact person. So I would decide, with the patient, if they're feeling well and the labs are normal and their exam is normal, we'll probably hold off on doing scans. But if there's something concerning, if there's a new pain, or even sometimes the patients are really anxious about it and they'll feel reassured. Sometimes we do a scan a year later after the treatment just to be reassured that the disease is not there. But I would really advocate for not doing a set interval, because I think then you're going to end up getting a lot more scans than you really need over a time, over a course of a disease that you're going to have for many years.
Great, thank you. We'll fit a couple more questions in if that's okay. We've had a lot of questions, and I know they can be difficult to answer just because of the limited data we have at this point, but we've had a few questions just about addressing the vaccine efficacy for patients with follicular lymphoma, and do you anticipate booster shots for them as well?
So as you can imagine, this is the most common question that I'm getting from my patients as well. So I think that we don't really know the answer for sure if the vaccine is working or not working well in an individual patient. I've had a number of patients request the antibody test, and I've had variable results where some people who have just gotten treatment who I thought wouldn't have had a response because they've just been going through this chemotherapy treatment have had responses. And then on the flip side, I've had someone off treatment for years whose test is negative. So one of the take-home messages is that I think the antibody tests don't fully assess the entire immune system. And so we don't know exactly what to make of that blood test. I think that most people are probably getting some response to the vaccine, but just the question of how much. So I think that, the number one part is that you have to keep being cautious, even, kind of assume that you don't have a response to the vaccine, continue to wear masks, really try to minimize, I would try to really be around vaccinated people when possible. I understand, I have a young child myself, so I understand that you have to be around your grandchildren. It's important for people to be around family, and so it's not possible to entirely be around just vaccinated people. But I think you just need to be cautious and know that you're at risk for that virus. And then regarding the booster shot, I think that's been the most common question I've been getting over the last week or so, and I think we don't know fully the answer to that, but I'm definitely in support of it. Once there's more of a national guideline about it, I think there hasn't been that made yet. I don't really see a downside to it, but I don't think it's been rolled out yet, so I don't think that, I'm not aware of anyone actually getting a booster shot yet. But I think that that's something that I would be in support of. Again, I don't know how much of a difference it's going to make. This whole time during the pandemic, there have been a lot of questions that we haven't been able to answer immediately, but that we get more information every time and better able to answer. But again, I would talk to your doctors about this. And again, I do fully support getting a booster if that's becoming made more of a guideline and is accessible for patients.
Great. Thank you, Dr. Our last question is, how can family members support their family member who has follicular lymphoma?
That's a great question. I actually became interested and drawn to this field initially because my dad had Hodgkin lymphoma years ago when I was a medical student. And so I think that, follicular lymphoma is a difficult disease from the standpoint of the patient for some of the reasons I've touched on, that, even though there is a lot of positive news about it, that people often live their normal lifespan and that the treatment can be mild, it's still, you're living with cancer, and it's going to be something that you're going to be facing usually for the rest of your life. And so it is anxiety provoking. It does cause stress. And so I think family members should just try to be, as supportive as possible and understand that like their family member may fluctuate in terms of how they feel about it, and that's normal, and just to be loving and provide a supportive environment. And then from a practical standpoint, I think, having someone available to drive them to appointments, especially if they're going to be getting treatment. Like, I don't like it when people come in for rituximab, for example, and don't have someone to drive them home or some safe way to get home, like in a cab or something, because you could feel tired from the drugs that we give you, like Benadryl and steroids. So I think from a practical standpoint, family members can really be there to help with rides and, and other support related to if there's procedures or other activities that the patients need to do. That would be a great way that you can pitch in and help them by driving them back and forth.
Great. Well, thank you so much, Dr. Rutherford. This has been a great program, and we are really thrilled that you were able to join us today. And we also want to thank everyone who was on today's call. We also hope you found the information both informative and hopeful. We'd like to thank our sponsors again for making this program possible, Bristol Myers Squibb and Kite, a Gilead company. Please remember, if you have any additional questions or you'd like to be connected with someone else who has been impacted by lymphoma through our Lymphoma Support Network, you can reach out to the LRF helpline at 800-500-9976. At the conclusion of this program, you will receive an email prompting you to complete a program evaluation. I ask that you please take a few moments to complete this, as they are very important to helping us deliver the most useful and meaningful programming to you. And with that, I'd like to thank everyone for joining us, and have a wonderful day.